she has to now send something to the Harvard HR. And then they're going to fix it, I think. I've emailed TFC. Contact with you. He hasn't been back yet. So I'll check in on Monday.
Yeah, that's it. Sure.
Before you start, can you unmute?
I think I'm already.
Camera is showing it. Sorry.
No worries.
I think it's because I'm short and I look weird for me. No, if you want to stand extra, and then you can let me know.
Oh, I see. All right. Okay, good morning, everyone. Thank you all for coming today. My name's Nathan. I'm one of the first-year general cardiology fellows. It is my honor and privilege to introduce today's cardiology grand round speaker, someone near and dear to us, Dr. Dawn Cutlip. As many of you know, Dr. Cutlip is an interventional cardiologist here at Beth Israel Deaconess Medical Center, the chief medical officer at the BIDMC Institute for Clinical Research, and a professor of medicine at Harvard Medical School. He did his medical residency at the University of Connecticut before we were lucky enough to recruit him here to Beth Israel for his cardiology and interventional cardiology fellowships. Over the past 2 decades, he has been an invaluable member of the HMS faculty, garnering recognition as a global authority in coronary artery disease management and percutaneous coronary interventions. In addition to authoring over 200 peer-reviewed publications, he has led multiple practice-changing clinical trials. He's currently the international PI for the Solutions trial, a multi-center clinical trial assessing the safety and efficacy of sirolimus-eluting balloons for the treatment of in-stent restenosis. In addition to his academic achievements, he is a beloved educator, winning multiple teaching awards throughout his career. I think I can speak for all fellows when I say that Dr. Cutlip's calm and thoughtful presence in the cath lab and in the CCU is always greatly admired, especially in the most complex and stressful situations. He inspires us all to achieve greater clinical excellence and become better cardiologists. Today, his talk is entitled Intracoronary Stent Restenosis, Forgotten but Not Gone. Please join me in extending a warm welcome to Dr. Dawn Cutlip.
Thanks, Nathan. Very nice words. Appreciate it. So we're going to talk about intracoronary stent restenosis and hopefully convince you that it's still important. Certainly not as important as maybe it once was, but still an important thing for us to know about. These are my disclosures. So when we think about the 40-year or so history of coronary intervention, well, what we see is really a cycle of innovation, discovering that things can be done better or complications, adverse outcomes, and then more innovation. And while a lot of that has been around the issues of safety in terms of bleeding and thrombosis and making procedures more successful, for at least the first 25 or 30 years of interventional cardiology, restenosis was a driving force behind many of these innovations. It is appropriate that we discuss it here at Beth Israel because many people have been involved in the concepts and leading the clinical trials that have helped reduce and improve restenosis outcomes. Starting with Don Bain, one of the pioneers in interventional cardiology, who most of us in the current group either learned from directly or indirectly, and Rick Coons, who really became the first interventional cardiologist to lead major clinical trials in this area. We'll start just with a brief definition, and I do this mainly to distinguish restenosis from more acute things like thrombosis, acute closure, and so forth. So restenosis is a gradual re-narrowing of a previously patent stent. So once you get a successful result, you leave, everything looks okay. And then within the first year, it re-narrows in the patient's back with more symptoms requiring intervention. This is a process that biologically, at least, is usually complete within the first 6 to 8 months. After bare metal stents, we'll see it goes longer for drug-eluting stents. And for drug-eluting stents in particular, neoatherosclerosis is also a factor in some of the late restenosis presentations. We often think of it as more of a binary angiographic definition where the stent re-narrows to more than 50% of its diameter. What we really care about is the clinical definition of restenosis. And we've defined this using a core lab to measure the diameter as greater than 50%, as long as the patient has symptoms or functional evidence of ischemia. And these definitions really aren't so important maybe for clinical practice, but they're very important for how we design and manage and report outcomes from clinical trials. If the patient doesn't have symptoms or we don't have evidence of ischemia or didn't do the testing to look for it, we also accept a core lab determined stenosis of more than 70% in the absence of evident ischemia. And if you think about it in relative terms, if the core lab costs something 70%, to your eye, that would probably look more like 90. So just how the core lab varies a little bit from how we visually interpret angiograms. And then the clinical trial endpoint that we get from this is something called target lesion revascularization, or we abbreviate TLR. And this will come up all throughout our discussion looking at the restenosis outcome. This is really the clinical endpoint, if you will, of restenosis. In terms of defining that diameter to determine how severe the restenosis is, it's the same as we would do for pre-stent procedure. We need to know the minimum lumen diameter, or MLD, and the reference, and then we can calculate the diameter stenosis that we all do automatically from our visual recognition. In addition to the MLD and the reference diameter, something that's a very important parameter is something called late loss. And this is just the difference between the MLD we get when the stent is put in and what we see at some time in follow-up. And the reason late loss is important is because it's a very narrow range for which restenosis will be low. And then above that range for a late loss of about 0.6, there's an exponential increase in the risk of requiring a target lesion revascularization. The other thing important about late loss is that it tends to be a fingerprint for a given stent. So if you take a stent, a bare metal or a drug-eluting stent, a particular design, and you do a trial of more than about 50 patients, the mean late loss is always going to be about the same. So I've shown here the late loss for the stents that we use commonly today. The everolimus and the zodolimus eluting stents have a late loss of about 0.2, and that compares to what we have with bare metal stents of about 0.8 to 1. So that's part of the reason the restenosis risk is so much lower in current practice. The other thing to think about is what is the lesion? So we say TLR, target lesion revascularization, what do we mean? It's not the original lesion that we treated. It's also not the extent of the stent that we put in, but it's the stent plus or minus 5 millimeters margin on either side. So re-narrowing anywhere in that segment would be called a target lesion revascularization at the time of follow-up when the clinical events committee adjudicates the outcome. The mechanisms of restenosis are recoil and neoangioplasty. Recoil accounts for almost all of the restenosis from balloon angioplasty. And we used to think it accounted for very little of restenosis for coronary stents, but as we treat more complex lesions, we do actually see recoil occur in heavily calcified lesions that have been previously stented. But still the main driver of restenosis after stenting is neointimal hyperplasia. That accounts for almost all the late lumen loss after stenting. We know the bigger that we make the gain at the beginning, the less chance there is for restenosis, even though the neointimal response is actually greater. If you put in a big stent, your late loss is actually going to be larger than if you put in a small stent. But restenosis will be lower because you can accommodate that growth of neointimal. So this led to the concept bigger is better. Sounds very mundane and common now, but it was actually controversial at the time that Don Rickers first coined that term. Even though we're going to look at some of the implications of later restenosis, it's helpful to look at 1 year TLR rates just to get a historical trend of where we've been and where we are currently. So with POBA, in clinical trials, restenosis was about 20 to 30%. In more complex lesions, this would be much higher, probably more like 50%, but they weren't treated in those trials. This was reduced about 25% experimental stents down to around 15%. Not a great big difference, but it was significant and was an improvement. And then the dramatic reduction that we have seen with drug-eluting stents to single digits of about 4 to 5%. Again, we're going to see this as a hold over time. One-year rates are obviously quite dramatically different.
Hey, Don, can you make a comment on the milieu, the background milieu of these patients too, statins? It's quite dramatic, but so has the medical therapy, or is that adjusted in some way?
No, it's not really adjusted, but for restenosis itself, as far as I know, Bobby can comment too. I don't think statins and medical therapy probably makes much of a difference. It's really more of a response to the injury. And I mean, the overall outcome certainly will be better if we looked at, MACE or bigger outcomes that include death and MI would be different. But if we look just at the restenosis,
Mechanical restenosis.
yes, probably not a big difference.
Okay.
Yeah.
Dawn, on kind of a parallel topic, is there a difference in patients that get stented or ballooned in the setting of an acute infarct versus chronic angina?
The difference in restenosis? There probably is some slight difference. Most patients who present acutely have lesions. We're going to look at risk factors, but their risk for restenosis is probably a little bit lower than a chronic stable patient, especially one with complex calcifying disease.
Yeah.
Okay, so I showed this slide not because we're going to go through all this, but just to show you kind of where we've been with restenosis. If we gave this talk, certainly 15 years ago, we probably would have to talk about all these different mechanisms and look at pharmacologic trials that were done trying to prevent or treat restenosis. But I'm showing it today just to show all that was important, but probably didn't matter so much when we got to the final common pathway of anti-proliferative drugs, preventing mitosis of smooth muscle cells was really what made the difference. And all these other things were important, and we learned a lot, but not as critical as the final common pathway to this. So this is some talk about the risk factors. We can sort of divide them into 3 categories: related to the lesion, related to the stent, or related to the patient. As far as the lesion goes, longer lesions is probably one of the most important factors. Small vessels, the other calcified bifurcation lesions, all these are very important. Acute thrombotic lesions, so not so much, Alice, being a risk factor. In terms of the stent, a lot of technical factors go into this. Under expansion is probably the most important, and thick stent struts is probably the other, but these other factors also enter in. And in terms of patient factors, diabetes is probably the most important, and chronic kidney disease follows closely behind. Some of the other factors, older age, female sex, may be actually confounded by vessel size and lesion length and so forth. And I just want to point out that on all these things, probably long lesions, small vessels, and diabetes are the 3 most important factors. And we want to give Kayla and Hope credit for doing the models originally that looked at this in bare metal stent trials. And we used to calculate patients' risk for restenosis going into a bare metal stent procedure based on his model of restenosis. One of the common misconceptions is that restenosis is a benign process. This frequently comes up, especially when we're thinking about CABG versus PCI treatments, which PCI always loses because restenosis is going to be higher. And it will often be said, well, so patients are happy to come back for another procedure to avoid CABG, which is probably still true. But part of that thinking is that we think of restenosis as being benign, and it certainly is not. We know that over 60% of patients who develop restenosis present with acute coronary syndrome, including 25% who have acute myocardial infarction. And about 8 to 10% of those will present with a STEMI because the restenosis can be totally occlusive and eventually become thrombotic. So it's not a benign disease, and we should consider these clinical outcomes when we think about it. The other important factor is that once restenosis develops, the recurrence rate is very high. At least 30 to 40% of patients will have a second restenosis. And about 5 to 10% of patients will have recurrent restenosis. It becomes a very difficult and problem. Much of what we learned came from the bare metal stent era, so I'm going to just talk a little bit about bare metal stent restenosis. Certainly, I've shown you already, bare metal stents did reduce restenosis compared to POVA. Most of this benefit was from eliminating recoil, in addition to getting the bigger lumen that we've already talked about. The problem was such that in a given day in the cath lab during the bare metal stent era, at least 20 to 30% of the cases you were going to do were going to be restenosis cases. Either a patient coming back with their first or one of multiple restenoses. Even though the biologic process of restenosis is complete in the first 6 to 8 months, we show that clinically the catch-up, if you will, for target lesion revascularization goes on for about a year, with about a doubling of the restenosis rate. We measured it at 6 months compared to measuring it at 1 year. So this became sort of the time of assessing the TLR endpoint. We show that after the first year, the hazard for TLR actually goes down dramatically to about 1.5% per year. In terms of relative terms, that seems like a small amount. And we actually made a big deal of the fact that restenosis is no longer an issue after the first year, and called more attention to the fact that non-stented lesions or non-target lesions were actually what drove outcomes after the first year. And that's all true, except I think we probably missed that this is really important, 1.5% per year, because as you'll see, that continues even with drug-eluting stents and even with contemporary treatments. So it seems small relative to 12, but it seems greater relative to 4. So having a 1% rate that continues over time will become an important thing that we'll talk more about. We talked about recurrences being around 30 to 40%, but it turns out it depends on what type of restenosis you have when you first present. This is work from Roxanne and Mehran showing that with focal restenosis, if you come back just with a single area, your recurrence rate is about 19 to 20%. But if it's more diffuse, which is frequently the case with bare metal stent restenosis at least, the recurrence rate can be as high as 80%. And once you've had that first restenosis, the recurrence rate is going to continue to be about 80%. So you end up with this population of patients who would come back over and over with restenosis. So better ways to prevent that and treat that are going to be important. We move then to the first generation drug-eluting stents. They resulted in a dramatic reduction in restenosis. It ended up being about a 50 to 75% reduction. Shown here on the right is an OCT image of a patient 9 months after stenting. And you see the struts here, all totally uncovered. No knee edema, no endothelial coverage at all. We actually quite unwisely thought this was a good thing. And there were trials being planned during the first generation drug-eluting stent era where all patients who had plaque, so like 30% or more plaque, would get stented because this was a cure. You see that's not quite true. Unfortunately, those trials did not happen. What was happening here was, in addition to preventing the neolentima, there was ongoing inflammation from the polymer and the toxic effects of the drug. So that's why we're not getting any coverage. We were also getting damage to the media of the vessel wall and malapposition, so the vessel would grow, but the stent was conformed to a certain position. So the stent was sort of hanging there in the breeze as an aneurysm might develop around the vessel, leading not only to late restenosis, but also late stent thrombosis. The pathology or histopathology of restenosis is different for bare metal and drug-eluting stents. We've talked already about bare metal being mostly neointimal proliferation, due proportional injury model, and frequently occurred in a diffuse pattern. Drug-eluting stents, restenosis is more hypocellular. It's more of a response to local inflammation and delayed healing rather than just a proportional injury. And fortunately, it often occurs in a focal pattern rather than diffuse. It also has a higher proportion of late presentation. It's the same absolute rate of late presentation, but relatively higher compared to the restenosis risk at 1 year. And how it looks on IVUS or other imaging is also different. This is a very homogeneous pattern, and here we get more of a layered pattern with drug-eluting stents. Just to talk a bit more about the late restenosis issue, these are data from the two pivotal trials. The first generation drug-eluting stents, this was sirolimus, and this is paclitaxel. We see they both looked really good at 1 year in the clinical trial patients with rates of about 4 to 5% compared to the 20 to 30% we would see with bare metal stents. But because of an ongoing hazard of restenosis by 5 years, this outcome is much different with restenosis rates now approaching 10%. Still better than bare metal, but not as promising or encouraging as we had seen at 1 year. The problem was magnified further when these stents were taken into the general population or real world type more complex lesions. These are data from a trial called Sirtax, which was designed to show which was better, the sirolimus or the paclitaxel. We ended up concluding in an editorial they were equally bad because by 5 years, the promising rates of restenosis of around 5% at 1 year had grown to 15%. So getting closer to the bare metal stent rate. And it's not our topic today, but for the same reasons of all this inflammation, stent thrombosis at 5 years was around 5% in these complex patients with first generation drug-eluting stents. So fortunately, at the same time, stents were being improved, partly in response to this challenge, but also actually the work had already begun by the engineers and researchers to make stents better. So we compare the first generation drug-eluting stents to the most frequently used second generation. The big differences were in strut thickness. So these had very thick metal, very thick layers of polymer, which made this a bulky device, which is part of the reason the outcomes were worse. The newer generations have very thin struts and very thin polymer only on the abdominal side. In most cases, it's more durable, it doesn't break down, and it's actually more resistant to thrombosis. These are data from an autopsy series from Renu Vermani. These are 149 patients who died more than 30 days after stenting, but within 3 years. They didn't necessarily die related to their stent, but she was able to get the autopsy specimens from all these patients who did die and look at them as late as 3 years later. And compared inflammation between the first generation, shown in these two columns, versus the second generation, shown here. And these are all different markers of inflammation. So uncovered struts went from 20% or so down to about 3%. Fibrin deposition as high as 50% with paclitaxel, down to less than 10%, and the inflammation score also reduced by about 75%. In the malapposition that we talked about occurring because of inflammation, around 20% with first generation, down to as low as 4%. The one thing that didn't change was neoatherosclerosis, and we're going to talk more about that phenomenon in a few minutes. But this continued at about 20 to 30% or so for all the stent types, although it seemed that the type of neoatherosclerosis was different for the second generation, seemed to be less vulnerable type plaque, thicker caps, rather than the more vulnerable neoatherosclerosis shown with the first generation devices. And this is important because the neoatherosclerosis, just like atherosclerotic lesions can rupture, it is probably a mechanism not only for restenosis, but also for late stent thrombosis. We could look at a lot of data from second generation coronary stent trials, but I'm just going to summarize it here. This is basically the same trial I showed you earlier from Sirtax, where we saw how badly the first generation performed. These are complex real-world patients with the two second generation devices, everolimus and zodolimus. So in the cath lab now, this would be our Synergy stent that we use here, and the Onyx is sort of the iteration of this device. By 5 years here, restenosis rates were only 7 to 8% compared to the 15 to 20 that we had seen with first generation devices. But importantly, still ongoing, still a hazard of about 1% per year, even in these devices. And perhaps even more important, although again, not our interest today, is that stent thrombosis is also reduced to like 1 to 2% compared to 5% we saw. At the same time, stents were being improved. It was recognized the first generation polymers were at least part of the problem. There was interest in developing bioresorbable polymer stents, and many trials were performed there. It certainly was an interesting concept. It turns out it probably doesn't make as much difference with the improved second generation polymers as it did versus the first generation. So the bioresorbable polymers perform better against bare metal in first generation, but perform about the same compared to second generation devices. Okay, so I want to just drive home the point about what's happening over time, because most of the patients we treat are going to be an average age in 60 to 70. So 1-year outcomes are important, 5-year outcomes, 10-year outcomes, or even longer are probably also, if not more so, more important. So this is a 10-year analysis from the ISAR group in Germany. Shown here, this is the second generation in the bioresorbable polymer devices, and in the light green is the first generation. So even at year 1, better, and consistently better over the 10-year period, but the annual hazard is about the same for all. So continuing to have about a 1.1 to 1.4% ongoing TLR rate between years 1 and 10. So you can see by 10 years, we have like 20% restenosis rates compared to the less than 10%. This is a more recent meta-analysis from Matt Avon and Greg Stone, looking at the 1-year outcomes and then a landmark analysis after 1 year. So clearly a big difference in 1 year. This is bare metal, this is first generation, and this is second generation. But after 1 year, they all track much more closely, and all with an ongoing hazard of about 1.1 to 1.5% per year. And if we look at other clinical outcomes related to restenosis, including myocardial infarction, this rate goes up to about 2% per year. So even though we've improved the drug-eluting stents a lot, our outcomes are obviously much better. We shouldn't forget that this is still an ongoing process. It still needs to be dealt with in terms of prevention and methods for treatment. So we just summarize the current state. We mentioned this ongoing hazard. We know from data published in NCDR, which Bobby was a co-author, about 10.6% of all PCI in the US performed during this decade was for ISR. And mostly I was due to DES ISR. So this is still, it's not what we had in the past, 20 to 30%, but it's still happening at a pretty high rate. And the clinical events related to ISR are occurring at about 2% per year. So to get a better handle on this problem as it's ongoing, we need a better idea of the mechanisms currently. And they can be divided really into 3 categories. There's the biologic mechanisms. And this is related to stilt and neointimal hyperplasia as the most common case. And it happens either due to drug failure or in patients that are higher risk, so especially in patients with calcified and so forth. And then neoatherosclerosis is another catch-up factor we've already mentioned, and we'll look at in a bit more detail in the next slide. Mechanical features or mechanical factors are also a problem, especially fracture. We talked a bit about recoil. This is the main driver for POBA, but as we treat more heavily calcified lesions, and actually it's somewhat related to stents becoming better. You know, the thinner strut stents probably don't have the radial support of thicker struts. So we do see some recoil happen as a mechanism for late restenosis. And then very importantly, because we have control over this, are the technical factors. So when we put a stent in, if we underexpand it, this results in about 20% of the ISR cases. If you look at mechanisms of a large series. Undersizing, I really wonder whether this is more of an issue related to underexpansion. I think undersizing has some role, but not as much as an underexpanded stent. And then we have to be careful how we pre-treat the lesion. So as we deal with more complex stenoses and longer lesions, and we require more treatments, more rotablator, shockwave, and so forth, for treating these big segments with multiple treatments, we may lose sight of how long we treated. And so the stent we put in has to be long enough to cover everything that we injured. So if we misjudge that and we leave areas that we pre-treated but didn't stent, it's called geographic miss. And we're going to expect to see high restenosis in those edge areas. Does that make sense? So just a couple more words about neoatherosclerosis, because I think it is an important factor in what we're seeing with late outcomes. It's really just a transformation of neointima to an inflammatory sort of typical, more typical atherosclerotic plaque is due to macrophage infiltration, neovascularization, and formation of thin cap fibroatheromas. The mechanism is thought to be related to a dysfunctional endothelial barrier. It happens probably because we've injured that endothelium, doesn't heal well, we leave gaps for macrophages to migrate into. And I'll leave better discussion of this to clinical scientists who look at these more. Turns out it happens both with drug-eluting stents and bare metal, but it happens earlier and at a higher frequency with drug-eluting stents. With bare metal stents, it probably doesn't happen until much later, like after 3 to 4 years. With second generation devices, it begins after about 9 months. Thin cap fibroadenoma can develop in about 50% of the lesions. Renu Vermani's group has looked at this a lot, does describe that the type of neoatherosclerosis appears to be different for drug-eluting stents between first generation and second generation drug-eluting stents in terms of the vulnerability, if you will, of the plaque type. The intravascular imaging is critical to defining these mechanisms. These are just some selected images looking at neoatherosclerosis. Here we see probable rupture of a thin cap fibroadenoma. And I think here you can see a lipid core within the plaque, which we can see on OCT. Cannot see this as well on IVUS. IVUS is helpful for defining under expansion. You can see well here, this is a stent in the vessel. The stent should be more out here. We don't know the size of this stent, so this could also be undersizing, but based on the size it should have been, this is really more of an underexpanded stent, which for whatever reason tends to trigger neoatherosclerosis and also triggers inflammation and risk for late thrombosis as well. Based on imaging, there's an updated classification of in-stent restenosis. Certainly not important for most of us to understand or remember all these mechanisms. But the concept is that based on the mechanism, we can decide the best treatment. So if it's a pure mechanical issue related to underexpansion, the best treatment may just be a high pressure balloon or other plaque modification techniques so we can expand that stent fully. If it's more neointimal hyperplasia, then a repeat drug-eluting stent or drug-coated balloon may be effective. And we're going to talk about how these two compare. But if it's a chronic occlusion where we know the recurrence rate is going to be very high and it's in an important vessel like the Prox LAD, it may be best to go straight to CABG rather than trying to prevent recurrent restenosis that's going to be at a very, very high rate. So this classification, I think, is helpful for deciding what treatment option is going to be best for that patient. In terms of treatment, I spoke earlier how there were so many different trials done looking for treatment. Everything failed. The first effective therapy was actually vascular brachytherapy. And how many in the room have had a patient or seen a case of brachytherapy? So believe it or not, we used to have to schedule our cases together with a radiation oncologist, and to be booked around their time because we were not allowed to put the catheter in that delivered the radiation. They had to come scrub into the case and be present for that. You put the catheter down with the beads, radiating, everyone leave the room. And these big bulky catheters had to dwell, I forget the time, but it was very uncomfortably long. It was like several minutes with this catheter just sitting there in the vessel. But it did seem to work.
The first year fellow was not allowed to start the report until they were done.
These are the two trials. One looked at beta radiation, which we tended to use mostly here. There was also a gamma radiation, a gamma trial. And compared to placebo, which is basically angioplasty, if you look at 2 years, because I think after 2 years, other things may be happening, there's clearly a benefit. Reduced to about 20% with brachytherapy compared to 30 to as high as 60% in some trials with placebo. Obviously, there's lots of issues with brachytherapy. One of which was that's how we discovered late stent thrombosis. Those patients came back, at the CEC, we would see a case of stent thrombosis, and in those days we thought it can't happen after 30 days. But after you start seeing multiple cases, that's where the late stent thrombosis issue. So when first generation drug-eluting stents were available, there was interest in how this might work against recurrent restenosis. And so they were also very effective compared to balloon angioplasty. If you look in this part of the table, balloon angioplasty had the usual 30% or so recurrence, and first generation BES reduced this by about 50 to 60%, highly significant advantage. And then this trial is comparing brachytherapy versus DES. And DES was also superior. Again, if you look just at 2 years, about 10% drug-eluting stents and about the usual 20% with brachytherapy. And this was also a significant benefit. So at that time, drug-eluting stents sort of became the preferred treatment. We were able to dismiss the radiation oncologists from the cath lab, much to their chagrin. Some of them might come in cases with us. There's obviously disadvantages to putting in more and more layers of drug-eluting stents. We don't know how they heal as we put in more. There's ongoing risk of late thrombosis and the need for prolonging DAPT as we get more and more layers. We also reduce the vessel biology, the flexibility, vasomotion, and we obviously complicate repeat procedures if the patient needs to have additional therapies, including jailing side branches. So I think it'd be fair to say probably the most exciting thing in this area right now are drug-coated balloons. You also see the term drug-eluting balloons because some balloons are just coated with drug and others are designed to actually elute drug from the balloon over the time that it's growing in the artery. So the engineers and researchers had gone back to the drugs we used for drug-eluting stents, so paclitaxel and sirolimus. It turns out paclitaxel is a much easier drug to use on a drug-coated balloon because of its biochemical properties. It's more lipophilic, so it can be dissolved in a solvent, put on the balloon and delivered. You can put a big dose on, even if you lose some, you get enough to the artery. And it also binds irreversibly to the microtubules. So once it penetrates tissue, which it does well because of the lipophilicity, it's binding irreversibly there. So it adheres and stays in the tissue, so you get long tissue effectiveness. There was reason to think sirolimus might be a better choice for the drug because with drug-eluting stents, the limus compounds tended to be safer and perform a little better than paclitaxel. But it doesn't work nearly as well as a balloon device because it's less lipophilic. So it doesn't like to go into the tissue. It binds reversibly. So if it doesn't bind and stay, it gets washed away distally. So it doesn't penetrate tissue and stay as well under just a coated balloon. So we have very inefficient tissue delivery and effectiveness. So this requires some engineering for how we get the sirolimus to the artery and how we leave it there long enough to penetrate into the vessel. So first, I'll look at the paclitaxel balloon. These are the dosages that I was able to find. So about 3 times what you would have on a drug-eluting stent for the initial delivery. It can be put with a carrier, so a solvent on the balloon. You do get a rapid drop-off in tissue levels, but it remains high enough and penetrates the tissue well enough and binds irreversibly that it tends to be effective. And these are sort of paclitaxel reservoirs that are shown within the vessel wall that allow this drug to be eluted, if you will, over time and prevent additional restenosis. For sirolimus, there are at least 4 and possibly more manufacturers who are trying to work out this. How do we get sirolimus into a drug-coated balloon that we can use effectively? We're working with MedAlliance, now Cordis, with the solution balloon, who have tried to solve this by putting the sirolimus into microspheres, so polymer-based microspheres, which are then coated on the balloon and covered with a nano coating of a membrane layer. So that protects the drug during delivery. And then the membrane adheres to the vessel wall when it's deployed, and the microspheres then allow the drug to be eluted over time. And this also has therapeutic levels for up to 90 days. There have been several trials looking how drug-coated balloons work compared to other treatments, such as drug-eluting stents and POVA. This is one meta-analysis of about 2,500 patients and included trials of BMS, DES, ISR, roughly roughly a little less than half of the patients had DES, mostly were DMS patients. What they showed is that both the drug-eluting balloon and the drug-eluting stent performed well compared to POBA, and they were not clinically or not statistically different to each other. So both the drug-eluting stent and drug-eluting balloon appeared to be effective in preventing recurrence. This is a larger, more recent meta-analysis, which also included second-generation drug-eluting stents, so the EES or everolimus patients are included here. And what was shown is that everolimus was superior to everything, including drug-coated balloons. And drug-coated balloons were not superior to everolimus, were about the same as first-generation drug-eluting stents, but were superior to balloon angioplasty, brachytherapy, and bare metal stents. So just one of the concerns that comes from this is most of these trials have looked at bare metal stent ISR, and there's some concern that drug-eluting stent ISR, which looks differently, histopathologically, we saw that earlier, maybe also behave differently. And in this meta-analysis from 10 randomized clinical trials that included patients both with DMS and DES ISR, we see that the drug-eluting stent and drug-eluting balloon performed about the same, equally well with bare metal stent ISR, but drug-eluting balloons did not do as well for DES ISR. And since most cases we're going to treat now are going to be DES ISR, I think this is probably an important concept to keep in mind whether they will be as effective as DES. We know they're as effective or more effective than balloon angioplasty, but whether they will stack up to DES, I think we need to have more data. I'm not going to show the US guidelines because we don't, well now we do, but we don't have data for drug-coated balloons to change our guidelines yet. But the European guidelines give a class 1 recommendation for both DES and DCB for treating ISR. They do recommend CABG for recurrent diffuse ISR, as we discussed earlier. So how about, so drug-coated balloons have been in Europe, probably how long? 10 years at least?
Yeah, maybe longer.
Maybe longer. So how about drug-coated balloons for the US? The FDA is cautious, we know that, and I think they were probably appropriately cautious because we need to have reasonable assurance that we're safe and effective. And I think for effectiveness, we have to be sure we're superior to balloon angioplasty, so that requires head-to-head comparison. And I think we'd also like to be non-inferior to DES, at least for those indications where a repeat DES may be appropriate. There's also safety concerns, which are very important for companies and for FDA. We're not going to talk about this. They were very concerned about distal particulates, like these microspheres and drug coatings that go downstream, what happens. For the most part, I think the companies have been able to convince FDA that's not a major issue. So in terms of the clinical trials, we can either do a non-inferiority trial to a drug-eluting stent. Becomes challenging because about 20% of cases get balloon angioplasty. We don't want to not include those in the trial. Or we can do a superiority trial of POBA, which is a good design. The only concern here is that the current data suggests over 80% of cases get treated with DES. So is that comparing the actual standard? In terms of data, I think we've all seen the trial that Bobby ran, the AGENT trial. 600 randomized patients, primary endpoint of target lesion failure. So this includes our TLR as well as MI and cardiac death as the endpoint. They enrolled a very high risk group, 50% diabetes. Over 40% of patients had not just one layer of restenosis, but more than one layer, at least two, and probably many cases of 3 or more layers of drug-eluting stent. So high risk for recurrence. And the results were very convincing. The target lesion failure rate for balloon angioplasty approached what we might have expected, about 30%. And the drug-coated balloon with paclitaxel had a much lower rate of 17.9% and a highly significant p-value. Looking at the secondary endpoints and components, I think it's also of interest. We're not surprised at the TLR difference, but there was also a difference in target vessel MI and a difference in what was called stent thrombosis because it met the definition, but likely this was restenosis with occlusion, leading to what look like stenosis. So should we be surprised by this finding that this angioplasty group had higher MI rate? We said 25% of restenosis is going to present with an MI, so probably not that surprising. These patients were also at higher risk for that outcome. We don't have data yet on sirolimus. We're involved in a trial here that we're enrolling into. With a plan to randomize 418 patients and we're up to about 360. And this will be a non-inferiority trial compared to standard of care, which is going to include 80% DES and 20% POVA. We're not going to talk a lot about non-inferiority designs, but I did want to show that we do have a high margin, high non-inferiority delta for this trial of 10%, which we justified based on how well DES does against POVA. So this maintains, well over 50% of that difference, which is what non-inferiority designs require. It doesn't mean we can have a 10% higher rate to not cross this threshold. The observed rate has to be about the same, maybe a couple of points higher than DES to be successful. I'm going to stop there and conclude just with a few key points. Quite dramatic improvements in safety and effectiveness. The second generation DES, clinical restenosis continues in about 10% of cases. Approximately DES, about half of the cases occur after 1 year. Very effective for 1 year. For the ongoing hazard, if we look out to 10 years, we're going to see 10 to 20% of patients requiring a TLR. Clinical restenosis is not benign. It's associated with myocardial infarction in about 25% of cases. With intracoronary imaging, we can generally identify the mechanism, and certainly imaging is mandatory in these patients who present with restenosis, so we can offer them the most optimal treatment. We know now drug-coated balloons are superior to balloon angioplasty, and we're hopeful that they may approximate outcomes with drug-eluting stents. Stop there. Thank you for your attention. We can take any questions.
I guess it's more of a comment than a question, but all of our patients come after they get a stent and say, well, how long is this good for? And I always say it's going to get through the first year, it's probably going to be good forever, but really, should I be saying to a 50-year-old, 20-30% chance you'll be back, or should we keep that to ourselves?
We can always say the stent lasts forever.
So maybe I'll choose my words more carefully, because now knowing this, I'm thinking, oh man, am I blind?
I tell patients the same thing.
Yeah.
First year is the most critical period. After that, there's an ongoing risk and it becomes very low. I think that's true. It is low. The 10% rate, right, is still 90% are doing well. I just think we have to enter it into our thinking, right?
Yeah.
Because not just for knowing the outcomes of stent cases, but if you're deciding between medical therapy and stenting and cabbage, I think knowing the restenosis rate and the thrombosis rate are probably important factors that should go into that.
Well, particularly 25% then of that resulting in MI.
Yep.
So I have a technical question and a clinical question. The technical question is, how do we, what is the endpoint of target vessel MI? Like, given that so many of these are in STEMIs, like how does one attribute them to the target vessel?
Yeah.
And then the clinical question is, for these drug-coated balloons, how long do we expect the effectiveness to endure?
Great question. Target vessel MI, the clinical events committee tries to determine. So patient presents, they go to the cath lab, it's a little easier. So we know if there's a culprit lesion or from the EKG. Most clinical event committees, if they can't decide, will attribute it to the target vessel. So the default can be to call it target vessel, unless there's clear evidence that it's not.
And then how long do we expect the drug-coated balloon to endure? 50% reduction in MIs or?
Right. And we don't have a long track record for drug-eluting balloon use like we do for drug-eluting stents. I'm sure the agent pages will be followed for 5 years. And the patients in the solution trial will be followed for 5 years. But we don't have a long time.
Are the European data though? I mean, they've had them for a while.
Yeah, I'm not aware there any long-term?
Yeah, there's some long-term data that suggests that, I mean, there's randomized trial data for the long term, which suggests that it seemed to be a benefit versus POBA that was enduring. And probably not quite as good as DES over the long term, but for the hard endpoints, similar. But there's recent data that came out of Sweden just a couple months ago that suggests that there was a catch-up, that DCBs had a catch-up to
You expect that.
POBA in that arm. But the concern there, and this is why it's going to be important for how we use these drug codes here in the US, is that in the trials, there's more image guidance, there's more meticulous attention to how the procedures are done when you get it out in the real world. You know, these aren't balloons that you're supposed to do like primary angioplasty with and just walk away, and you really need to, like what's Don was alluding to, the underlying mechanism of restenosis that you identify in imaging is really important. If you have an underexpanded stent there and you put a direct loaded balloon in it, you don't address the fact that it was underexpanded, it will restenosis. So that's going to be important. But we'll find out. If you looked at the aging curves, at least they were separating all the way out to a year, but it'll be interesting to see if they.
That's a good point about the drug delivery. So the drug coated or drug eluting balloon is just to get the drug there.
Right.
All of your angioplasty pre-treatment has to be done before. And until you have a successful result, you should not put in drug coated balloon. And at least with the solution balloon, you shouldn't do anything after, because you don't want to disrupt the drug.
It was really fantastic historical and contemporary overview. And one of the things that struck me is just over so many years how much the BI has had an important legacy in this space, from the original and for you in particular, and Kaylin and the HCRI and the Bain Institute. It's really I think a stamp on this important thing in the field. My question is, there's some recent data that came out just at EuroPCR this week on a stent which we're hoping to do a trial in the US, which disarticulates and then it sort of unhinges, and maybe that was, there's promise for drug-coated balloons and de novo lesions, this sort of year upon year of the stented vessel failing. What technologies do you think, is this a technologically solvable issue for the sort of year-on-year inexorable rise that we see in stent failure or vessel failure? And what technologies are you most excited about or skeptical about? And are there other lesion subsets for drug-coated balloons that you're, I think, interested in exploring? Multiple questions.
Yeah, I mean, I think there is a ceiling of how good we can be. I mean, I'm biased, but I don't think our restenosis rate is 10% here. And I think part of that is because we're so careful during the procedure to make sure it's successful. So I think that can be, there's still going to be a ceiling, but I think it can be lowered by good planning and good procedural technique. And imaging is a part of that, even though I don't always do it. Certainly in most cases, I think it probably does let us get there. So I think we can probably be more like 2 to 5% than 10 to 20, but still some ceiling. And I don't know the answer. I'm hoping drug-coated balloons will offer something. I think that what we'll see is that the drug-eluting stent will always be the best treatment, probably for recurrent stenosis. But if we can reduce that from 100% to 10 to 20% of patients who need that drug-eluting stent, to me, that's a win. And I think the other place where drug-eluting balloons will be useful is probably in small vessels. And we're going to be involved in the trial here with that eventually. And maybe bifurcations, especially when the single bifurcation, which is a 001, where it's just a side branch. I think treating that with a drug-eluting balloon and avoiding having to stent back into the parent is probably a good use for these. Yeah.
And you're talking about the index intervention.
Index intervention, yeah. Yeah. So and again, in Europe, way ahead of us, they've been using drug-eluting balloons for de novo lesions, not ISR. But you have to be pretty brave, because you have to be very aggressive in your treatment, which means going back a bit to the angioplasty days, where we didn't have a choice. We didn't have stents. So you would leave dissections, hazy, bad-looking vessels, but it turns out they do okay. And the restenosis risk seems to be low, and they've avoided that initial layer of stent in the first place. And it seems to be something very reasonable. They end up stenting about 20% of cases, so they don't leave everything, but that's still 80% of patients who would have gotten a stent who don't. So our trial here won't be all lesions, but it will be doing that with small vessels, which FDA allows us to define up to 2.75 millimeters. So it's, not that small.
And is this the clinical situation an MI or ACS, or is it just chronic stable angina or
Chronic stable
ischemia?
angina or stable or recovered non-STEMIs, not STEMIs, but and in Europe, they are doing STEMIs, I think, right, with Intracoronary.
Don, do you have a sense, a great talk, how many cases here do we use concomitant imaging just in general, or across the US? Do people will do IVUS or OCT to make sure the stent is okay?
Yeah. Across the US, it's very, I don't know the exact number, but I know it's low, it's probably as low as like 10-20%. Here, it's operator dependent. And I think most of us have started using it at least 50%. Bobby, Eric.
Yeah, we've sort of bimodal, I would say, in our lab. We have some 20% users and we have some 90% users, and I think we average out to about 50 right now. In the US, it's increased recently and it's now up to about 20-25.
Are there financial incentives to use it? Or
Distance centers.
Yeah.
It's not a hospital reimbursed,
It's not.
it's part of the bundle that the hospital gets paid. There may be a small physician payment, nothing that would drive anybody to take the extra time to do it, because if you're gonna use it, it takes time. But so
This
in
cost.
fact, there's and there are randomized trials showing that image guided PCI has better outcomes, hard endpoints, than non-image guided PCI. So it's something that we ought to be doing, certainly in the in-stent restenosis cases, but probably even more than we do.
In the modern era, it's one of the few things that's cost saving. From a societal perspective, it's like one of the few things we do that's cost saving, is image guided versus regular PCI.
Yeah, I mean, I'd say for
Versus cost.
those of you who are like all of you who are referring cases to the lab, it could be something that you ask for, and that would drive our utilization up. I think we all encourage it in our
Oh, man, I love
conferences. But
I think
you
what
ask,
happens
hey,
though is
did
instead
you
of
do PCI, did you do image guidance? I'll bet you that our utilization will change a little faster.
instead of requesting image guided, we just request the provider.
No, but this is better, we could change behavior.
That's true, yeah, we could.
Request image guiding PCI.
I don't know if it'll change behavior.
Spread it out.
You tell the interventionalist what to do.
Eventually.
Oh, yeah. Oh, not from patients, but within.
Thank you.
Thank you, Don.
It works sometimes.
But it does seem like,
How's the OCT look?
Oh, yeah.
They call you after it's over.